A large iridodialysis with phacodonesis and 1/3 circumference of zonular dehiscence is being managed for cataract surgery and repair of iridodialysis. About a millimeter behind the limbus, a straight partial thickness scleral tunnel is created after a conjunctiva tenons incision. A 2.8 millimeter entry is made into the eye. 1% lignocaine in the anterior chamber. In addition to the topical is the anesthetic that's used. Through the tunnel floor entry technique, I am doing a rexis starting from a point beyond the iridodialysis. Tunnel is enlarged to 5.2 millimeters. Inner lip of the tunnel is widened to minimize the trauma to endothelium. Iridodisection. Vitreous herniation was noted at the tunnel, which was trimmed with Van Ass scissors. Nucleus is rotated within the capsular bag by manually so that there is no stress on the zonules. Without any pull or push on the zonules, the nucleus, epinucleus mass is rotated very gently into the anterior chamber. Care is taken that zonular dehiscence is not increased. The pressure inside the anterior chamber is atmospheric, and the 25 gauge cannula continuously injects viscoelastic in front of the nucleus to protect the endothelium. A good capsular hydrodissection facilitates complete removal of the cortex. You can see the very low aspiration and infusion pressures in an open chamber will not hinder the surgery. There is no iris prolapse or vitreous into the anterior chamber at this time in the tunnel. The IOL can be placed in the capsular bag, and the haptic is positioned in such a way that it exerts little push on the zonular dehiscent area. A 2.8 millimeter keratometry is made opposite to the iridodialysis. A 10-0 polypropylene suture, model 6902 pp of Aurolab, with a long curved needle is used to anchor the iris to the peripheral sclera. The entry of the needle is 1 millimeter away from the limbus. The needle is railroaded out through the tunnel that's made. The iris is counter supported with a bent cannula. Guided by the open Macpherson forceps, the reverse passage of the 10-0 pro needle is made, and it's again railroaded through using a 26 gauge needle. So the suture passes in and out of the sclera, which is about a millimeter away from the limbus, and now on pulling it, the periphery of the iris is anchored to the sclera. A 3-1-1 knot is created to anchor the periphery of the iris to the sclera. This is cut close to the knot so that it gets buried in the scleral groove that was initially made. The scleral tunnel is closed using 3 10-0 monofilament sutures. Any vitreous herniation is checked by infusing the anterior chamber with 1:5 diluted triamcinolone. Vitrectomy is using a probe is avoided in this particular patient to minimize the extension of the already dehiscent capsular bag in that area. The 3 sutures are no compression of the tissue so that not much of astigmatism is created by them. The sutures are cut very close to the knot. The knot is buried in the sclera. We are not planning to remove this post-operatively. The aligning of the proximal and distal portion of the sclera has to be perfect to prevent the kinking of the sclera. The sutures are basically to avoid or prolapse of intraocular contents postoperatively, and to minimize the astigmatism. Ensure that the passing of suture across the tunnel is not shifting the tissue laterally. That will minimize the amount of surprise astigmatism one can get. The temporal tunnel also will minimize the amount of surgeon-induced astigmatism. The entire surgery is being done at low intraocular pressure with low flow and low aspiration, done by Simcoe cannula and a silicone bulb. Also note that there are no side ports and a phacoemulsification machine is not needed for this surgery. All the knots are buried inside the sclera. The other option that I had was a positive pressure surgery to remove the cataract and to put an endocapsular ring and capsular segment to anchor the capsular bag into the sclera, and this is a very elegant technique, very minimalistic approach, and basically the difference would be the extension of zonular dehiscence is totally avoided by the minimalistic surgery, which involves very low fluidics, very low aspiration, and zonular dehiscence was prevented from getting extended. And the post-operatively, the patient has done extremely well with well-centered IOL. The pupil is slightly peaked towards the dehiscence, but that's not creating any problem to the patient. A 26 needle is passed away from the tunnel, and it sweeps the angle region in that area to remove any incarcerated vitreous fibers from the angle region. AC is formed, moxifloxacin is infused into the eye, and the conjunctiva tenons is reposited using fibrin glue, and this covers the tunnel very effectively post-operatively. There is no need to bandage the eye. The patient can start using eye drops post-operatively. The pressure inside the eye is not very high, it is just adequate. Thank you.